Hello, everyone. Today I have Kelly Craven, who is a registered surgical nurse and a bodybuilder. How you doing, Kelly?
I'm doing well, thank you.
All right, let's get started. What inspired you to go into nursing?
Well, it goes back quite a ways, actually. I was a paramedic in my early days. I was actually the youngest paramedic in the state of California when I went through school. My grandfather and father were fire. My dad was a medic back in the day. And medicine has been a big part of my emergency medicine has been a big part of my life for a long time, actually, since I was probably two or three. But I had gone into bodybuilding for a number of years, and the girlfriend at the time was not doing anything. She decided to go to nursing school, and she went through, and I was helping her with all her homework. And in doing that, so she said, "How do you know all this?" I said, "I don't know. I just do." She said, "You should go and, go to nursing school." I said, I kind of blew it off. Well, she convinced me to go take the entrance exam for West Coast, and so I did. I went and took the entrance exam. I got 99 out of 100. And the lady literally said, "When would you like to start?" And I said, I don't have the money for that right now. It's not really in the plan. I got to work. And she basically said, "We have financial aid. We have night schedule. We work around work around it." And I was like, before I knew it, literally a week later, I was in class.
Wow,
Yeah. It dumped me in really quickly, but yes.
that's very unique. I've never
Yeah.
really heard that before. That's
Yeah.
pretty cool.
So,
So, about like helping her with her homework, do you think that like your bodybuilding knowledge that comes with like anatomy and stuff like that helped you out?
no, actually, when I was a medic, I a little back history. So one of the surgeons I work with, and who actually just worked on me last week, him and I are really good friends, and we've been good friends for almost 20 years now. He he knows how much I love medicine. He actually gave me there's a anatomy physiology book. It's called The Netters, and you know what it is. It's a very well well written book. It's got great diagrams in it. It's very informative. And for my birthday one year, he bought it for me, and it was kind of like my bathroom reading. And I just medicine has always been part of me. I love it. And in bodybuilding, the reason why I was so successful in my personal training in bodybuilding is my knowledge of the body, the chemicals in the body, the different medications, etc. So yeah, so I think it helped a lot, but it was beyond the bodybuilding aspect. It's been a love of mine for a long time.
Yeah, that's incredible.
Yeah.
So, for someone doing a more typical pathway, what does the RN path look like? Because I think that's a little bit less known than doing like becoming an MD or a PA or something.
Yeah, I think that a lot of from my experience, a lot of RNs, most of them that I know of have a family member who's a nurse. Their mom or their dad or somebody pretty close to them is a nurse, and that's why they went. And they know that it's good money, it's a great career, and it's always in demand. So the normal would be going through your undergrad, and not most don't. Most come out of high school and they have no idea what they want to do, and they go to nursing school. And most nurses are not BSN, get your bachelor's degree in nursing, and they go that route. That was an option for me as well if I wanted to do that. There was other schools out there for a lot less money, but I am one of those people that I don't take the lower route. I don't buy the lower end anything. I always go for the highest of everything, and so I went and got my BSN. So a lot of people go out of high school because they don't know what they want to do, and there are hundreds of different routes after you get your RN, from the clinical setting to the reps. A lot of reps I know actually are RNs, and they went that route. But the surgical reps, of course. But yeah, it just depends on what influence they had. And I mean, it could be as simple as, "Hey, my friend's going to nursing school. It sounds cool. Let's do it." And some of them are the best nurses I've ever met.
Yeah, that's so cool. Is there like a difference between getting your bachelor's in nursing versus getting like a bachelor's in biology or something?
Yeah, application.
Mm.
Absolutely. Yeah. I mean, it depends on which route, I think it's all typically, or, really is the applications you're going to use it for. If you get your bachelor's in nursing, you have doors that are just, I mean, there's thousands of doors that you can open with that. If you have a bachelor's in biology or, psychology or whatever else, you're pretty limited. Your scope is pretty narrow.
Okay. So if you think about nursing, just go all in is
Yeah.
what I'm hearing from
Yeah,
this.
well, you go all in, and then once you get that degree, you have so many different avenues that you can go, and paths that you can take to, figure where your niche is. And a lot of them takes a long time. Some take several. Some they just go into a clinical setting and they stay there. Some go to the retirement homes, and it's very easy and it's stable and it's consistent, so they never leave. But it just depends on what you're looking for. And a lot of people, do it because they enjoy helping people. And a lot of people will go, hey, this is really good money, and I'm going to go that route.
Mhm. Yeah. How does the specialization in nursing work? Do you have to go through some extra schooling, or do you just apply for a job at whatever you want and you just
Well, that's the unique part about, I mean, I think the individual actually, but, you and I have never really personally met, and gone and have conversations, but, I consider myself a very unique person, and, I meet a lot of people. I talk to a lot of people, and I, people are blown away. Like, I tell stories about something, and they're like, Kelly, somebody and everything. I said, and I can back it all up. There's not a story that I haven't told that's not true. And there's not and it actually opens my eyes up sometimes because of the amount of experience, the amount of things that I've seen. But it's because I'm a go-getter. I'm not afraid to have a conversation with someone, talk to the doctors, go, hey, why are you doing that? How did you get there? What was that path? But when it comes to specialization in nursing, I'm an OR circulator. I can do pre-op and post-op, but I'm also an ER nurse. So, and there are very few of us. There are very few people who can do all of it. I'm not saying that they're not smart enough, or they don't have the drive, or they just, they're not capable. It's just a lot of them don't have the patience, don't have the reserve, because I currently work with 24 different doctors and as an OR circulator. And every doctor, like has their specialty. They like their things a certain way, their local anesthesia, their positioning, their whatever instruments they want, etc. They have a way. And if you don't know that, you're not going to survive. The OR setting is a very unique setting. It's fast paced, and you better know what you're doing. Otherwise, you're not going to survive. And when you're a nurse, and starting out, there's very few facilities that are willing to put that time into you for a number of reasons. Number one, if they train you for, let's say, $40 an hour, they train you and they put in 6 months into you and they give you this great opportunity. Well, your eyes open up and you realize that there are jobs down the street that are paying you 50, you know, and what are you going to do? You're not going to stay working for that facility because you're loyal. You're going to go, I need to make that extra money. I'm sorry, I'm gone. So that's why a lot of facilities will not take new nurses and train them to be an OR circulator because of that.
Yeah, that's actually not something I ever knew or even considered.
Yeah.
So I'm sure you've heard recently that in California, they got rid of non-compete clauses,
Oh,
where you
really?
can just hop around for without any repercussion, I guess. So do you think that that benefits the profession of nursing, or
I
that?
actually don't think I've ever come up in my profession in nursing, because you are most, and that's the other part. A lot of nurses now in California and a lot of other states, you hear travel nursing and you hear medley nursing and you had registry nursing. So I think that doesn't really apply to us because a lot of facilities don't care, how loyal you are. They need someone tomorrow, and they're gonna, okay, great, you filled in that spot, that void for a day, and that's it. The next day they might have enough staff on hand, but the non-compete, I personally haven't had that, have that happen to me. I have not seen it. I have not heard of it. I know what it is. I just don't, it does. I don't think it really applies to the nursing field, because we are replaceable at a cost. and that cost may be that medically nurse or registry nurse or whatever travel nurse. They may be expensive. They may be charging $20 more an hour. But you got to take the other end of that in. They're not an employee. They're not being paid benefits. They're not getting, sick time. They're not getting all those other things. You basically walk in the door, they pay their own insurance or, all their own gas and all the other stuff that they're taking care of. And when at the end of their shift, they're gone. So at the end of the day, they're actually saving a lot of these facilities money because they don't have to cover that because, and most people do, insurance in California is ridiculous.
Mhm. Yeah. You especially encounter that in the ER where there's lots of people who don't have insurance
Yeah.
or
Yeah.
have
Yeah.
problems with their insurance.
In the ER, and I see it every day, and a lot of people are afraid to come to the ER because of that. They don't want to come back because they're going to get a bill that's going to be $5, $10, $15,000 because they were there for 45 minutes. And it's accurate. They do. I've seen it. I've seen someone come in, they were there for less than 4 hours and their bill was almost 10 grand. And it's like, how? I was there. I saw what was done. It does the medical field. There's a lot of changes I think need to be made in that and regulated, but it's not happening anytime soon.
Yeah, that's true. Have you noticed that, like, I guess nursing in particular has a lot of problems with staffing?
Yeah, that it actually happens every day. Like, well, today, the facility I was working at today, that of, they were Thursday. My supervisor texted me and said, "Hey, are you available to work on Saturday?" Which I normally would say no because those are my days, but hey, I'm like, okay, I'll pick it up and take it, but normally I wouldn't. But if I didn't, they would have been hiring a medically nurse, and the doctor that was working today would have been pretty frustrated because that medically nurse doesn't know him, doesn't know what he likes, doesn't know his style, doesn't know, all the little ins and outs. They're probably pretty good and they can survive it, but it's not going to be ideal. Then that doctor is going to be frustrated at the facility. Then the doctor is going to be possibly thinking about, hey, maybe I should take my cases elsewhere. So staffing is a huge problem in the nursing industry, even though there are a good amount of nurses out there. That's a constant battle in nursing, especially in the emergency room where I work in the ER too. And, that is a constant battle because for some reason, out of all the fields I've ever worked in, nursing has been the one where they have no problem calling out sick because, I just wasn't feeling into it today. They stayed home, because there's going to be a bunch of other nurses that can cover my area or something like that, but
That's very interesting.
yeah.
Why do you think that that's the case with nursing specifically?
I think because we're in such high demand that most facilities are afraid to fire them, especially in California, because of retaliation issues. But they're also, hey, if you have a nurse that's capable of doing that job, but they only come in, 15 of their 20 shifts a month, that they, positive outweigh the risk or the problem because they're just, they're covering 3/4 of their shifts. And so they're like, okay, well, we'll find someone to cover that. So I think that that's the main reason. I don't think that there's enough consistency to staffing for them to go ahead and say, you know what, we're going to be hard on these people and fire them because what are they going to do? Replace them with new grads? The facility I work with is 90% new grads. There's very few of us that have more than, I would say, 2 years experience. And if you were going to the ER, if you were an ER doctor and you were working there, and you rely on your nurses hard, like that's a heavy part of you rely on them. They are thinking for you and giving you the input that you need to make before you make that decision, because we are a huge part of that decision process depending on the patient, because we know the patient, they don't. And my doctors trust me, and if I recommend something, they're like, you know what, yeah, let's do that, or hey, how about this instead, and then we go back and forth. With a new grad, they're not doing that. So that means they have to work that much harder, because a lot of ER doctors now are not paid because they were on that 12-hour shift. They're paid by how many patients they see in an hour, and which is another whole nother avenue that I don't agree with, because now we're talking about a business instead of patient care, and safety. So, yeah, but I think that's the main thing. I think that staffing in nursing is that biggest problem in nursing, and that is it for sure.
Yeah, and everyone says that nurses are the backbone of the healthcare system, which is completely true. But
Absolutely. They're also
what happens when that, everyone believes it, And because everyone believes it, they know that, like, they know their worth.
Yeah. Then they know what they can get away with.
Exactly. That's the better way of putting it, I guess, in this scenario.
Yeah.
Yeah, that's insane. How do you balance your, like, working in the surgery, working in the ER, maintaining like the your hobbies, your bodybuilding? How did, like, it seems like a pretty difficult thing to do.
When I first started, so I after I got my nursing license, I worked for about a year, and then I had a family member come down with something that was very hard, and I had to take some time off to go help them, which I financially was capable of doing, which was nice. So I took about a year off and helped that situation out. I was still nursing, but I was more of a family member. But going to I get off, say I have a 12-hour shift. It's 7 to 7:30. My drive is 35, 40 minutes. I actually had to switch gyms because my gym closed early, so I had to find a gym that closed at midnight. And so I made that change. And so I would get off work at 7:30, get to the gym by 8:15, change, start working out. I work out till 10:30, 10:45, get home by 11, shower, get in bed, and be up at 5. um, and that was a normal, very regular normal. And I would pick up shifts. There was a stint there where I went 47 days straight, and yeah, that was a lot. It took a lot on me. I lost 15 pounds. And so, but because you're not getting your meals in, you're not training as hard, you're tired, you're burning a lot of calories, especially running around. But and you're also, most people don't realize your brain burns a ton of calories, and it's said that your brain burns 2/3 of your calories on a daily basis. I don't know how much that's true, but it's pretty accurate. I mean, when it comes to, your brain needs a lot of energy, and when you're thinking and you're problem solving and you're trying to work with X amount of doctors in a period of time, you're burning a lot of calories, and if you're not keeping up, you're going to lose weight. So that was a very hard thing. And having two sons that are pretty active, that are older, that I've got a 13 and 14-year-old. They keep me very busy, and so trying to do that, and my partner and my girlfriend, she keeps me very busy as well. So it's a lot, and it's a lot of balance, a lot of understanding. And I try to, I'm actually backing off a little bit right now so I can spend more time with everybody. But some of us get lost in that. Yeah, it's great money and it's a lot of work, and we get into work mode, and we'll go for quite a bit of time before we need to shut down and take a break. Otherwise, it'll burn out.
Yeah, and burnout is a huge problem nowadays.
Yeah.
Not just with nurses, but with like your MDs, your PAs, your NPs. Like, it's crazy, crazy, crazy. How do you personally combat something like burnout?
I go fishing.
That's a good one.
I'm active outdoorsman. I have a lot of hobbies. I actually had to take a few hobbies out of the stint for a little bit. I'm a big hunter, a big fisherman, a big off-road guy. I've got a lot of big trucks and stuff, and I've got a saltwater reef. I've got a lot of hobbies that I do. So I have to kind of back off. I used to be an avid golfer, and I had to back off that. You end up having to choose, and it's unfortunate because there's not enough time in the day. And there's not enough time in the week, and you got to start choosing what is where your passions really lie and what you do. And one of my main passions right now, because it's changed over the years, but one of my main passions right now is fly fishing. I'm an avid fly fisherman. I go all over the country. I plan on going to New Zealand next in October next year to go for 2 weeks to spend, go fly fishing. But I was actually fishing in Montana about a month and a half ago when I ruptured my tricep, as you can see there. But yeah, so I'm an avid fisherman, and that it keeps it that kind of gives me that namaste where you take a little breather, and it's like, okay. And in between that, there's a lot of driving to get there, and so it gives you time to think and relax and kind of take it all in.
Yeah, that's really important. Just time with yourself also, just internalizing and reflecting.
Yes.
So in the ER, I'm assuming you also work with a lot of nurse practitioners.
Actually, no.
Really?
No, actually, I work with I think 3 nurse practitioners. One of them has been a nurse practitioner for quite a long time, and she is my she's in charge of my stroke department. I'm NHS certified, so I handle. I mean, I'll have, depending on the week, but 3, 4, 5 different strokes in a week. Sometimes 2 in a day. But there's only a few of us know how to handle them properly, so we got bombarded. But when it comes to nurse practitioners in the ER, the ER that I work at, very few. There's, most of them are MDs, newer MDs, and some are older. But yeah, I think I work with, I think, a total of 3 nurse practitioners right now.
Interesting, because I know the ER that I work at, there's a lot of PAs and a lot of NPs.
Really, that's
Yeah,
interesting.
it's like I think it's a very community based hospital, but there's a lot of people there. So
Yeah,
I think that's just a function of how big the ER
I
is.
wonder if that's not because of the ability of a nurse practitioner or a physician's assistant, and the price point at which they could, have them on board. Because an MD is going to be a lot more money than a nurse practitioner, of course. But I'm curious. I mean, I don't know. I mean, yes, they're capable. Yes, they're. I'm sure they're just as good to a certain degree. But I've worked with some absolutely amazing nurse practitioners. I've actually worked with more nurse practitioners. Actually, they're MPs. They're yeah. Let me see here. Physician's assistants. Most of the ones I work with are physician's assistants in the OR, and a lot of doctors have their own, PA, especially in the orthopedic world. And let me tell you some. There, I work with one over the hill, and I watch the doctor and him synergistically go through, and we'll do a total knee replacement in 38, 40 minutes. Which is ridiculously fast. If you know anything about OR in, orthopedics, a total knee for a normal surgeon, hour and a half, hands down. That's going to take them. But these guys are literally swapping instruments in tow, going back and forth, suturing, putting it. It's impressive, and so.
Yeah, and I was going to talk about how, or piggyback off of what you were saying about doctors' different styles, and they have to learn that. So, how important is that as a nurse, but also as like a tech or a PA? I mean, you said they do a total knee in 30 minutes, which is
Oh,
wild.
if you don't know your doctor, you're not going to survive. The OR is a lion's den. And if you're soft skinned, if you have a thin skin right there, you're not going to make it, because you're going to get yelled at. The doctor is going to yell at you at some point. The doctor is going to get furious at you because you didn't have whatever it was. Now, you weren't 3 steps ahead. If you're in the OR and you're not 3 steps ahead of the doctor, you're behind a mile, and you are going to get yelled at. And I've seen a lot of nurses break down and cry, and just they're gone. It doesn't work. So you take your licking. You realize, hey, this is what he likes. You make sure you make a note of it, mental note, personal note, physical, whatever you need, and you move on. Otherwise, you're done.
Yeah, that's huge. That OR culture can be very malignant.
It's brutal. Yes, it gets brutal. And I mean, the doctor I worked with today, he got very frustrated over a couple little things. It wasn't very big, but it was also getting late, and he wanted to be done sooner, but it was more him than us, and the patients were a little more difficult, and it happens, and you get backed up, and he wasn't having it. So he wanted to lash out to feel better, and it's fine. We all know him. We knew it was coming. No problem. It wasn't disrespectful. He was just frustrated, and brush it off, move on. Next.
Yeah. I've seen on social media that there's a few nurses that just get, I don't know what the right word is here, but their doctors are not so respectful to them.
Yeah.
And that could end up becoming a problem. How big of a phenomenon is that in nursing?
I think it's a pretty big issue. I think that it's a phenomenon that happens more often than not, but also, there is some truth to, maybe you're not cut out for it. Maybe that's not where you should be. Maybe you shouldn't be in the OR because you aren't. If you're, look, there's a difference between a doctor being an asshole, excuse my language, or he's just going, hey, I like this done a certain way, and I shouldn't have to ask you to, do this, or put this tool there, or whatever. I want the fluoroscope in a position like this. You either know it or not. And if you're not capable of stepping and go, doc, I understand it's my first time, I'm learning, I promise you I'll have it down next time. If you can't do that and you can't voice your opinion, you don't belong in the OR. I have no problem stepping up and going, I understand, sir. Take a breather. I promise you I will have it down. Just be more clear with what you're telling me. I won't forget for the next time. And I'm taking notes. And when they realize, I think that's a key one. When they realize you're taking notes, you're showing them that you care, and that you're going to make it, the next time it won't happen again. Now, if it does happen again, you're probably not going to make it in the OR. But yeah.
Yeah. That's a huge thing that I've noticed, is when someone shows that they're willing to learn and that they're wanting to learn, people are much more receptive to that.
Absolutely. Well, it shows that you care and that you value your position there. Okay. The ones that don't care, and the ones that are like, yeah, okay, yeah, and just blow it off, or it's like, what, no, you weren't meant to be there. You need to move on. And the doctors will voice that opinion.
Yeah. And that's a hard thing to accept.
Yeah, because people sometimes, they want to blame the other person, when sometimes maybe it's not them.
Yeah. And especially if you've gone through like school to become an RN, and you've had some experience before, but then you realize maybe this is not right for me.
Yeah.
And yeah, that's huge. And in medicine, in all types of medicine, you have to be very adaptable.
You have to be very adaptable. Very simple today. The patient came out of surgery in a lot of pain. We gave him the pain medication, and come to find out that he's having a hard time getting his pain medication through the pharmacy. The pharmacy didn't have it. You need to figure it out. You're not going to send that patient home. That's poor patient care. You're going to send that patient home with no medication. We can't give it to him. We can't go. So you have to find the doctor, get a hold of the doctor, find out what the solution, what we're going to do. And we did. We found a pharmacy that had the medication he could use, and called it in there, and he's going to have to pick it up. He's going to have to pay out of pocket, and then he's going to have to have it reimbursed. But if you're not willing to do that, and you're just like, what? Sorry, you should have had this already done. You're in the wrong place. But what you said a minute ago, you all this here in school, there isn't a specialty nursing school. Which I think there should be to a certain extent. I think there should be some, hey, you know what? Once you get to your last year, you should be doing just like you guys, as doctors, you go in, you decide which route you want to go. You want to go orthopedics, you want to go peds, you want to go, cardiovascular, neuro, whatever you want to do, but you're going to do rotations in that department so that you can start specializing that area. In nursing, they don't do that. And I think that would be a crucial step in providing the right nurses for these specialty spaces. Between, you want to do home health, you want to do IV infusions, you want to do ER, you want to do, telemed, you want to do, ortho, you want to do general surgery. I got lucky. I had really good doctors around me that were willing to kind of give me a little leeway on teaching me and showing me. And they vouched for me and said, look, he doesn't know everything, but he knows a lot, and he's willing to learn. And I got lucky, and I have several nurses on a daily basis in the ER going, hey, how'd you get into surgery? Because there is more money in surgery. And they asked me, hey, how'd you get in there? I want to do that. I'm like, look, I got lucky. I got lucky, and it was not just luck. You pursue it, you push for it. You're not afraid to apply. You're not afraid to go, hey, look, I'm willing to do this. I'll learn this. Give me a chance. And it's also personality. And a lot of people don't have that drive and that personality to go out there and go, hey, you know what? I want to do this. If you're not going to show me the opportunity, I'll go get it from somewhere else. And you possibly are missing out on a good nurse. But if there was a specialty, I think that it would be even a secondary school. They people went through 2-3 nights a week. It'd be a very successful endeavor.
Yeah. How prepared do you feel out when you just graduate nursing school?
None. Very little. You might as well. You're stepping into a work environment where it doesn't matter what they prepare you for. It doesn't matter how many the values and what drugs it doesn't matter, because you memorizing drugs is not going to help you. You going, hey, well, I think it's this one. Once you have real world application, that's when you start gaining knowledge. that's when you start going, hey, you know, well, you see the patient's going to tell you a story. Then the doctor's going to tell you a story. Then you're going to see the chart, and that's going to tell you a story. It's when you put that story all together, that's when you get the book, and that's when you learn, you know. And I don't care what it is, from, you know, a patient with DKA. I mean, my first DKA, I had no idea what the hell to do. I was lost as could be, but I had a great preceptor. My nurse was just absolutely amazing. And it was amazing because people around her didn't know that she was that good of a nurse and actually doubted her. And when I heard about it, I'm like, you guys are crazy. She's brilliant, you know. And she taught me a ton. And let me tell you something, I will never forget, I had a case by myself. Patient came in. I'm like, that dude's got, you know, nice fruity breath. He looks like he's in DKA. Doctor came over and goes, you think so? I said, yeah. He said, let's do some blood work and see what his anion gap is. Let's check it out. Bam. Sure enough, it was like 21 or something. And we're like, okay, you know, and we were on pain meds, and we were instant. We were doing it, and we got on top of it right away. And that lady, actually, I ran into her in the ER a month later. I think a month later, and she saw me. Right. When I saw her, she was not coherent. She looked like she was forgive me, a meth addict. And I would have not known the difference. And when I saw her come back in the last time, she actually walked up and she goes, remember me? I said, I do remember you. How you feeling? She's like, I'm doing so much better. Thank you so much. Can I give you a hug? I loved having you as my nurse. I'm like, you absolutely can. And she gave me a nice big old hug, and she's like, thank you so much. I hope you're always here, because I have this issue a lot. And I was like, it was blown away. That was the first time that patient experience was just like, there you go. I was wrong. I didn't know what was really going on. And I learned, you know, but a lot of people have no idea, you know, and if you don't have a good preceptor, you're not prepared, you know. And I went through 6 different preceptors when I came out of school, 6 in the same hospital. And they were too consumed with themselves and just collecting the extra $2 an hour, I think it was, to precept, than it was to actually show me knowledge, show me, train me, show me what they know. Even though whatever I knew, it didn't matter, but this one did. It took me under the wing. We're still friends now. We
Wow.
still talk often, weekly, you know, and yeah, catch up. But yeah, you know, and not everybody gets that lucky, but I am blessed. I think that I try to generate that kind of surrounding. So, but it doesn't prepare you whatsoever. You come out, you are green as can be, and you are not liked in the ER for sure.
Yeah, from the way you describe it, it seems like a very cutthroat profession.
It is. It very much is. Yeah, it's unfortunate because, you know, you'll get a couple that'll be a good team player, but on any regular shift, you're on your own. Even your charge nurse is most of the time you're on your own.
Wow, that's kind of unfortunate to hear, because
It's scary. It's unfortunate. It's you know, yeah. It's amazing how many nurses do not survive in the ER, and they will never make it. I mean, a lot of them go into home health or tele. I actually, when I first got hired at this hospital, I was hired to go into the OR because I knew the surgeon there, and the head of the surgery department was like, "Yeah, you know what? If you're a friend of his, I'm gonna give you a shot." And we're like, "Great." Well, they were only doing 8-hour shifts. And I said, nah, and morning, which the traffic, it would cut 3 hours out of my day. I'm like, I'm not willing to do that. And so they ended up telling me, hey, why don't you come over and go to telehealth? Go to tele. And I'm like, oh, okay, you know, sure, whatever. You know, I just want to get some experience in my belt. So I was scheduled to go in there. Well, my first orientation day, I was walking in and I met the ER director walking in, and her and I were talking, and she says, you know, oh, where are you going? What department? I told her. She's like, oh, and I told her I was an ex-paramedic. And she said, and you're going to what department? She goes, no, you're not. You're coming with me. My first day, I never worked a day in tele. She literally grabbed me, put me in the ER that day, and I was in the ER. And so when we transfer patients, my first time I transferred a patient to tele, I was like, oh, I would have been a very unhappy person in tele. I am too active. I need too much, you know, I'm very, you know, I need a lot of things going on. I would be bored out of my mind, you know. But yeah, I am glad I made the choice I made, and now, and I was still able to get into the OR, which is great.
yeah, that's incredible. That like shows the value of just saying yes to as many experiences as possible.
That, and again, being friendly and, and not being afraid to say hi to someone, because that's all it was. It was a simple good morning, how you doing? And that's all it started. And that was it.
Yeah. I've talked about this in some of my other interviews, but being outgoing is a huge bonus if you're trying to move around in medicine and trying to like climb the ladder, I guess.
Yeah.
Do you have any tips for the shy person who's maybe wanting to be more outgoing?
Don't be afraid to say hi. Don't be afraid to introduce yourself to your doctors, because they think they're gods. I'll tell you what, I'm not a new grad, but I'm not a 20-year vet, and I'm gonna tell you right now, I can go through my phone and call every single one of my ER nurses or doctors, every one of them. And if I have a question or I have something going on, they'll answer. I had lunch with one the other day, and he's actually he's a director now at a hospital in Kentucky. Yeah, he's only been he's actually an ex-paramedic. That's why we got along so great. But I would have never known without having that conversation. But you don't know who they are or where they came from unless you have a conversation. But at the end of the day, they're like you and I. We breathe air. Okay, we wake up in the same place, every day. We go to work. We are no different. I don't care what education you have. You're not better than me. They're not better than you, and that's where the people like, oh, I will absolutely, and I do no matter what. I give my doctors the utmost respect, even my CRNAs. Okay. I call them doctor. And they're like, oh, no, I'm just a CRNA. I said, no, you are a doctor of anesthesia. Okay. If you are able to anesthetize a patient, you are a doctor. In my eyes, you're a doctor. So I give them that title. And most of them have a doctorate of some sort. And like, well, I'm actually a doctor of such and such. I'm like, that's fair. You're a doctor. This is the education you have. You're higher than me by a lot. And you know what? I respect that. So, I think that if you come respectfully and have conversations and ask questions, I think that they're good questions, not dumb questions. You come and ask, hey, I've got a potassium of 134, or I'm sorry, sodium 134. What do you think we should do? It's like, they're going to laugh at you. Like, no, you come out when it's 120. Now we're having a conversation, but it depends, but outgoing, you can't be afraid. You got to be able to go ask the questions, and use your brain. If you're not capable of doing that, fast-paced OR is not the place for you. You belong somewhere else. And there's plenty of positions for that and need for that. But that's the difference.
Yeah. Hopefully I'm not asking any stupid questions.
No, these are great. I mean, it's actually funny because I'm in the ER or the OR today. We're talking about, oh God, what we were talking about. We were talking about something, and my tech goes, Kelly, you really do know like a lot of people. I'm like, because I talk to them. I have no problem asking the questions. I have no problem, even it may be a stupid question to you, but it's something that I wanted to know, and so I'm gonna ask it, and you'd be surprised at the response you'll get. Some doctors will be like, well, that was stupid, or like they'll give you an attitude, whatever. Okay, not gonna hurt my feelings, but like I said, if you have that soft shell, you're not gonna make it. You don't belong in that department. You belong in tele or med surge or whatever. But you're never going to be an ICU nurse. You're never going to be an ER nurse. You're never going to make it in the OR. So, and it comes to the best. I think I've met some of the most amazing nurses were ICU nurses. Okay, some are ER nurses that just don't want to go any further. They're happy with that setting. You can run a code. And with minimal staff. Yeah, that's pretty incredible, but yeah, you just can't be afraid. You got to be able to ask the questions, say hi to people, and that's it. And it'll go a long ways.
Yeah, absolutely. And I want to pivot a little bit to the CRNA comment that you made.
Yeah.
How does that kind of schooling work of basically adding extra letters to your RN of like critical care nursing or licensed travel nurse or licensed vocational nurse? How does that pathway work?
Well, most of them require some sort of extra like experience. Most of them won't even talk to you or see you if you haven't had at least a year of ICU, because most places go, hey, you know what? They look at ICU as being the king. right? If you can handle, 5 different pressors on a patient who, you got a blood pressure of 60 or 40 over, like 30, and you got them on 5 different pressors and it's not working. You're trying to think outside the box what to do. And you're dumping, a pint every 5 minutes. And these guys, you can handle that setting. Okay. For a number of year, or for at least a year, they think that you have enough to put that extra energy in because you're willing to go the extra mile and move forward with your career. All the CRNAs I work with are all anesthetics. They are extremely intelligent. My doctor, friend of mine, they've actually, a couple have actually tried to get me to go back and get mine. I'm done. I have no desire to go back and get my CRNA. I said I have plenty of friends that are CRNAs, doctors, and they're smart as hell. And I'm perfectly fine supporting them. I have no desire, but it's, travel nursing isn't really a credential, it's experience. You can go do travel nursing after a year. ICU is, critical care. ICU critical care is basically taking a class and getting a little more experience. ICU nursing, if you can get in, okay. But if you want to go and get your CRNA, you have to have at least 1, maybe even 2 years of CRNA of ICU, and then you have to apply. And even if the school accepts you, then you got to find a preceptor. I have a friend of mine I went to school with. Him and I were classmates. Took the exits together, took the NCLEX together. We studied together, and he's extremely intelligent, and he wants to go and get his CRNA. And he's younger than me by quite a bit. And he's like, look, I'm going to do it. I said, you got it. You're smart. Go get that. But he's like, look, I can't get an internship, with an anesthesiologist. Like, I got you covered there. I have 5 that I work with. And if I tell them, hey, this guy really wants it and I vouch for him, they will absolutely give you a shot. And I know that he'll live up to it because he's a smart guy and he works really hard. So, but those extra letters, in some places, they mean a little bit. And we're talking, maybe up to $10 more an hour, sometimes 20. If I went back and got me, I could go take a class and go get my nurse first assist. And their jobs out there, they're in the $90 to $100 an hour, which is, for a nurse, is incredible. That's nurse practitioner pay without the extra schooling, because it's only a couple classes to get that.
Yeah, that's incredible. I think that's a path that is a little bit more hidden.
It is, and I think a lot of people, once they get their RN, they went through. It depends. Your RN is one, but your BSN is brutal. The BSN path is brutal. It is extremely difficult. There's a lot of papers, and it's much harder than just your regular nursing license. But I think that and by the way, in order to go any further, you have to have your bachelor's. You can't go any further. So that's why I chose to get my bachelor's, because if I decide I want to go further, I better have this. So, but yeah, all these avenues are hidden, but at the same time, it's only hidden to ones that don't want to look, or are too afraid to go any further, or don't care to go any further.
Mm-hmm. Yeah, being too afraid is something that probably a lot of people would resonate with, is because it is scary to go just head first into something you don't really know about, you've never really seen before.
Yeah.
So yeah, that's how you said, just comes with time. Like, just say hello to people. Just
it does. But you also have to be confident. If you're not confident in this field, you're not going to make it. You may make it as a tele nurse again, or home health or something. But I had a acquaintance. He went to a school, got his pre-zel done, and when he found out I was in nursing school, he told me, he's like, hey, why do you go there? That school's so expensive. I said, because I'm going to come out making good money immediately. He's like, well, I can go here for less amount of money and then go to Mount St. Mary's, and it'll cost me a third or a half of what you're spending. I said, yeah, but I'm going to come out making money immediately, and it's going to take you 2 or 3 more years to finish school to get there. And unfortunately, his Mount St. Mary's at that point had lost their accreditation for a period of time, and it takes a lot to lose that. So I don't know if I want any part of that, but that's up to him. He ended up coming to my school, and I saw him there one day, and I said, oh, you came over. He told me why. I'm like, oh, that kind of sucks. But he graduated. He took his exit exam. He barely passed that. And then he took the NCLEX and he failed it. He failed it 3 times in a row. And the new NCLEX is now much easier to case study. They give you all the values, they give you all the information, and you basically are just kind of going through a case together. And that's the NCLEX now, unfortunately, because the one before that was one of the hardest things I've ever done. And the test was so brutal. I thought for sure I failed. I was 1,000% sure I failed, but he failed 3 times on the regular NCLEX, and then they came out the new one and he passed. And so that shows you what the nursing community is doing. The nursing community is lightening up on the prerequisites to be a nurse, because we are so short staffed, especially through COVID. I think that's why they did it, because COVID was such a big problem with staffing, and how much they had to pay. I mean, nurses were making $1,200 a day, $1,500 a day. It was incredible money. So I think that's a lot of it.
Yeah, that COVID messed up everyone.
COVID was brutal.
Yeah, especially in the ER. I'm sure that was a very, very rough experience.
It was very rough. The amount of bodies that were being placed in certain areas because we had nowhere to store them. It got crazy. It was one of the hardest things I've ever seen.
Wow, that's my hats to you. That's incredible. Thank you for your service. Quickly, what is the NCLEX exam?
The NCLEX is the National Registry for Nurses. Once you pass school, that you have to become a registered nurse.
So it's like the bar, basically.
Basically, the bar. Yes, it's exactly the same thing. It's like it's their standard that you need to practice as a nurse, RN. A registered nurse. You cannot get that license without that. And even if it doesn't matter if you're an RN or a BSN RN, you still have to take the NCLEX. Okay. They have one for LVNs as well. It's a lot smaller. But it's a very unique test. And when I was taking it, you had max of 145 questions, minimum 75. And when you started out, if questions got easier, that means you weren't doing great. And as you started doing better, they got harder. And they were either multiple choice, select all that apply. They're put the right sentence into this position. But it was brutal. It was extremely hard.
Yeah, that incredible. It's again incredible.
It was one of the hardest things I've ever done. And to my defense, I put in, major hours studying. I mean, I studied for a month straight. I took every practice question I could find. I think I did over 10,000 practice questions. I studied, 10, 12 hours a day. It's a lot. It's crazy because a lot of the things that I learned, studying for that, I have applied already in the real world.
As a paramedic?
Oh, as a nurse.
Oh.
As of now, after seeing all these things, I've been able actually to apply it, and see it, from an API to DKA to, just a regular old seizure to you name it, hey, oh yeah, there's that, but yeah, it's pretty interesting.
Yeah. I've got a question about scope of practice between like someone who's an RN or like a nurse practitioner. What can you do that, or what can't you do that a nurse practitioner can, or the other way around?
So I'm not really 100% on that, but I know that a nurse practitioner, and I know the laws are changing right now, and they might have already changed, but a nurse practitioner is very close to a doctor. They're allowed to prescribe. They're allowed to diagnose. They're allowed to work on their own and practice medicine without a doctor's supervision. They used to have to, and don't quote me on this, but I knew at one point they were required to work under a doctor for, I think, 3 years before they could start working on their own as a nurse practitioner and actually seeing patients and diagnosing and prescribing medication or drugs, etc. As a nurse, we are not like that. My scope as a paramedic was a lot higher than I am as a nurse. I could do IJs, I could do intubation, I could pass a lot of meds without having to ask permission. As an RN, I can't pass meds without permission. I have to have a doctor's order. I can't diagnose. That's not in ours. But I mean, I can't intubate as an RN. There is, I can suture if I have my first assist, if I go and get that, which is fine. But As an RN, you are limited to what the doctor, allows you, permission to do or give. But yeah, there is a pretty big difference between the two.
Okay, yeah. That does that like limit you as a person, or like how does that impact the way that you practice as someone who's had experience before? And
It, I have been, lucky enough to have doctors let me intubate because I used to, under their supervision. I've had a lot of doctors let me suture, which, because I know how to do it. I am certified to do midlines because I can do ultrasound guided IV, which a lot of people don't have the wherewithal, don't want to. I don't know, because but I'm one of the few that was certified to do that at the hospital. So if there's a difficult IV, I was the one that was doing it. This was a midline that had to be put in. I was the one that put it in. But it does limit me because it's like I want to knock this case out. I want to get this done, and I know I can do it. And I know what needs to be done, but I'm limited because until that doctor comes in, sees the patient, gives me the order, I fulfill the order, that I can, discharge, with et cetera. I'm limited, so I have to hold on to these patients for 2, 3, 4 hours because they're seeing other patients. So yeah, it gets a little frustrating when you have to do all that, but that's the chain of command. That's the order that's set in place. And a lot of times that's good because a lot more checks and balances in there.
yeah, especially if some, like how you said that after nursing school, you don't feel prepared.
Yeah.
There has to be that gap of
Yeah.
time.
Yeah. Yeah. But
Would you say that nurses should have like a residency or something similar?
No, I don't actually. And the reason I say it depends. I mean, because I think that if you are, in the nursing field, if you're working with one person as in residency, if you were to work in a facility where you were working with several different people over a period of time, I think that would be more beneficial. But I don't know if a residency would help per se, because most facilities kind of do one already. If you come in as a new grad, they're going to put you through their new grad program, which is going to be 12 to 16 weeks of training. And you're working with a nurse, that's hand in hand. I think it'd be more beneficial if you had nurses that were skilled and experienced and good teachers and proven, that could mentor you appropriately. I saw some that would be hands-on with you and teach you a bunch. I saw some that would go, I teach from afar. Go when you fuck up, or excuse me, when you mess up, you come back and we'll fix it. It's like, wait a minute, no, that's the whole point. You're supposed to be with me. And I've seen it all. And I think that if you have, like I did, I had a really great nurse. I think that if I was a facility, I'd hire her and pay her, X amount more an hour, and I'd have her work with students, work with nurses, to improve our nurses and make them better, get our new grads out there, so that they're capable of doing things on their own, and maybe them teaching more people, but yeah.
Would you say that also the preceptor problem, I guess you'd put it, impacts the amount of nurses that can go out and practice effectively?
What do you mean? I mean, because there's not enough of them?
You said that you went through 6 of them because there were just some who didn't teach you well or had some other problem. Do you think that issue, that the preceptors are not always consistently good?
Yes, that's kind of where I was going with that. Is if you had a specific group of preceptors that were highly knowledgeable and willing to teach you, and they were not burnt out, because that's the biggest problem, and they were excited to still come to work and still help. But that, I think the bigger problem isn't necessarily them. I think that's the management. And that's the bigger problem, is management is not doing what they're supposed to be doing to make sure that you get the training that you need. Okay. In the facility I was at, she acted like she was on your side. She did everything she could, to, make it seem like that. But when you start seeing the true colors, it was more like, well, you're just a number. You were just a number. And I actually told a buddy of mine this. In the ER, you're a number. In the OR, you're an asset.
Mhm.
And that's the difference, because in the OR, I could leave tomorrow and I have 10 different job offers. In the ER, I could probably leave and have 10 of them, but they don't want that. You are just a body. In the OR, they want to keep you because they don't want to, they like, having someone who knows what's going on, what's doing. But in the ER, you don't necessarily need to know everything you're doing because you have a doctor dictating what you can and can't do. Okay. They don't need you to set up anything. Oh, they need a hand trace setup or a suture kit or, yeah, whatever, but that's simple stuff. It doesn't take a lot of mind work to do that stuff. So I think more of it is the management side of things is the bigger problem, especially in the ER.
Yeah. And I think that's also, like how I said before, that's just not something that people take into consideration, is how important the way you're managed is. Because if you're managed poorly, you can't do your job effectively.
Yes. And that's very true. And I think that a lot of ERs have become too bureaucratic, and they're not hitting the numbers they require. So a lot of them there are on their heels trying to cut back costs and do whatever they can to run it really thin, which puts us at a dilemma because that makes us unsafe. And what I realized at a couple different ER facilities, they don't care about your license. Because at the end of the day, if you mess up, it's your license. They're not going to have a problem. They're going to say, well, he acted on his own. He did this, So that's, and having to watch out for yourself, that's a big problem, especially in the ER.
Yeah. Have you noticed, or how about this? Is there like a specific patient that you saw or a specific person that you talked to that was impacted heavily by the bureaucracy of just healthcare in general and the ER?
Every single day. Every single day, I have one or two that are absolutely being affected by poor management at the hospital. And we have an area, it's called green zone, and we have an area called yellow zone. Well, it's depending on what level they are of triage they come in, but you come into green zone, and you escalate up, to a higher level of acuity, you're going to be moved into yellow zone or into a bed, depending on what's available. And a lot of times these patients will sit there for a couple hours before they're seen, and it's because the management isn't keeping track of what's actually going on, or staffing the right amount of nurses. Because I've been in green zone and I've been so far out of ratio that I've actually had to say, hey, I'm not comfortable with this. You need to get another nurse over here, or you need to stop bringing patients back because I'm not doing this. And they frown upon you saying that because they don't want that problem, right? But at the same time, I'm not willing to risk my license. So there's been several, and I've had patients complain to me about me because I'm not able to provide the care that they require or think they require, right? Even though they were a high acuity, but you know what? Every single patient's important, and they want to be treated, like they are number one in the ER.
Mhm.
You have one patient that has a case of gout. You have the patient next to you who's an AFib. Who are you going to see first? You're going to see the patient in AFib. Well, the other guy was there first. He's going to be pissed off, and how do you handle that? What do you talk to them about? Well, if you're out of ratio and you don't have another nurse to come in and help that person, you're going to have a bad day, and it happens every single day.
Yeah. And that, are you saying out of ratio? Do you mean like in the California law of there's one nurse for every 4 patients?
Yeah. And I will literally turn a patient, and before I even come back, there's another patient in my bed.
Oh
And I'm not kidding you. It's literally, that's how busy the emergency room is, and or my emergency room. And and then then you get behind, and now they're, hey, we ask for vitals every 2 hours. You're 3 hours past, blah blah blah. It's like, what do you want me to do? I'm only one person. I can only handle so much. If I'm handling an ICU patient here and another possible ICU patient there, which if you have ICU, you're only supposed to be 2-to-1. Okay. Well, that patient's not technically ICU. Oh, he's got a pressor on board. That's an ICU patient. I don't care what you say, but they're not on your side. So you've got to advocate, and you got to, figure it out. And so the more you document, which is crucial in the nursing industry. The more you document, when you get a patient, when you hand off a patient, what you did, what you gave, what was hanging, what was running, where it was running at, how much oxygen was the patient on, etc. It becomes a more of you covering your ass than it is a patient care.
Yeah, that sounds exhausting.
It is.
Like, you got to remember every detail and every. Is there something that you personally would want to see revised in that ratio or something else?
I don't think the ratio per se is. I think that I think a better system. If the patient is at a certain acuity, they should never be placed in a certain area. But it's not realistic, and it takes too much deductive reasoning to figure out what patient would go where and how and why, and it would take more managerial skills, watching the patients, where they were, how they were, what they came in as, etc. It's just. I would just rather see if you had more LVNs on the floor, I think, or techs on the floor. I think that is when I have a good amount of techs or good techs on the floor, I have a good day. If I don't have good techs on the floor that are helping me, watch patients, hey, I noticed this, the patient wants this, etc. Can you get this? You'd be amazed how much time it saves you by having those techs help you.
Yeah, absolutely. And almost everyone says that or knows that.
And like I said, and good techs. I've had some that are, and I don't understand why they keep them on board, but they do. And, they'll go clean one bed and go sit down in the corner.
Yeah.
Things I could have you do, but you know what? I'm not going to ask you because, you're just going to, backlash. So, yeah, unfortunately.
Yeah. I've seen in the OR the consequences of a bad tech.
Yeah. Oh, yeah.
It slows everything down.
It does.
So much.
In the OR, though, it's a little different, though, because in the OR, a tech is, scrubbed in, handling, the instruments, and is a crucial part to that surgery. Crucial. In the ER, a tech is cleaning beds, hooking up the patient. When the patient leaves, putting new leads out there, making sure that, the bed's ready to go, make sure all the equipment is in there that I would possibly need for the next patient, that kind of stuff. So if they don't do that, then I got to go get all that stuff. I got to make sure my stuff's ready, and that time and that resource. It's just now I'm back. Now I'm behind. Now I'm out of ratio.
Yeah. And regardless, they keep the operation running.
It doesn't stop. It's not like, oh, give me timeout. No, doesn't happen.
Yeah.
OR at tech there's no timeout. And the OR, you better move your ass. You better really handle it. And I think that a lot of techs in the OR. In order to get to the stage where they're actually scrubbed in with the doctor, I think that they've already passed a lot of that. I mean, I have a new scrub tech that I'm working with right now, and the first couple times I worked with them were a nightmare. He ran over my foot twice in the same day with the gurney. I've never had my foot ran over the gurney. He ran over twice. So I finally had to talk with him and say, look, this is what I want you to do. Don't do this again, please. Until I'm ready, you don't touch that bed. Don't move that bed. Don't touch that bed. I don't want you to do anything with that bed. And I worked with him today, and he was great. He was much better. He's learning, which is good.
Yeah. Pivoting back to what you said about confidence, right?
Yeah.
You're a very physically imposing guy, and you've been working out for a long time and things like that. Do you think that your background in fitness helps you in nursing, like a philosophy that you picked up from there, or just the size that you gained?
Yeah. I instantly get respect from the patients almost before I say a word, especially the prisoners. There's a lot of prisoners that come in, and I'll come around the corner, and the first thing, every single one of them, not just one, every single one of them, as soon as I come around that corner, they see me, they kind of pop up. And they say, I see you, big dog. The first time. That's the first thing they say to me every single time. And I'm like, very respectful. How you doing, sir? Good to see you. Blah, blah, blah. And sometimes I'll ask them what they're here for or whatever, or I'll keep walking. But a lot of my patients, they see me, I'm in shape, I'm a bigger guy. You would think I'm pretty intimidating, but they're there because they're in their time of need. And you'd be amazed how many people that doesn't really ever come up about being intimidated. They come up like, oh my God, this big man's going to save me and help me, and I get more of that. I get a lot more love than I would get any issues that arise.
Yeah. And that probably helped as a paramedic too.
It wasn't as big when I was a medic, but but as a medic, it was a little different, but Yeah, 'cause especially being in the out of and when you're not in the hospital, and your place has changed, where you could be on the side of the road or in a house or in the bathroom or whatever, it's a little different.
Yeah. And that being in shape just gives you instant credibility, right? They
That
know, oh, you take care of yourself, you can
yeah,
take care of me.
it gives you a level of respect, and and especially in these days where you see all these, I hate to say it, but these fat phobic, people with these questions, these stigmas, these all these things that come up, they're trying to normalize this. Like, no, you see people who are large, and I'm not saying a lot of them are it's a physical disability, and it's not just because that they eat too much or they just don't take care of themselves, but a lot of it is to a certain degree, right? But there are people out there who are just big people, and be surprised. I do get some pushback from some of these people because they think that you're going to push your agenda on them, right? And so some once in a blue moon, I'll get a little attitude, but I'm usually able to squash it and make it up to them.
Yeah. And you in the ER, obesity is a problem.
Huge. What's the number one thing you see? You're going to see diabetes, right? You're going to see, patients are on, all kinds of heart medications, right? Most of them have COPD, right? And be surprised how many of them have lost a limb, missing toes, missing feet, missing arms, and whatever. But, that's a huge thing, and you try and talk to them and you try and make sense to them, but most don't care. They're not going to change.
How do you think the new GLP-1 agonists are going to take the burden off of the ER, or just help in general with people's fitness or
I don't
health?
know. Don't know if that's how much it's gonna help, or how much it's gonna just be a fad. It's gonna last for a short amount of time, and because it's still fairly expensive, and a lot of people are taking. I've seen it. It works. I have, man, it works. I have never taken it myself, but I have known people who have, and they're 30, 40, 50 pounds lighter. Which is fun. It's changing lives, but it's expensive. It's really expensive. And, it also, we in the ER or the OR, it causes a lot of problems because we can't do surgery if you've taken it within the last week. It's a protocol, for bleeding, we just don't do it. But I don't know how much of it's going to take off a burden from the ER, because I feel like just because you are taking something that's going to help you lose the weight doesn't necessarily make you healthier.
Mhm.
Doesn't necessarily mean that you're not eating and drinking or smoking, or doing drugs or et cetera. So I don't know how much, I would maybe a couple percent, better, I don't know. And it's yet to be seen. It's good. I would hope it would make a big difference. I just don't see, I haven't seen anything like that. And I think it's going to be a number of years before we do see that, we do.
Yeah, absolutely. And the technology of like the pharmaceutical technology
Yeah.
is rapidly advancing with them. There are less side effects, greater main effect. Like, but also, I don't think a lot of people are thinking about that they're still smoking or they're still drinking or their diet is still
Shit.
not
Yeah.
good. It might be less calories, but it's the calories they're eating are just not up to
Yeah.
par.
They don't realize that their liver and their kidneys don't like those items, their stomach, it is, and people, they think this is a miracle drug, which it is. It absolutely is. But just because you are losing the weight doesn't mean that you are healthier. It's like saying a guy who's got, big muscles and, he's, a giant bodybuilder, doesn't mean that he's necessarily healthy. You don't know what the liver and kidneys are looking like in there. You don't know, their A1C could be freaking 9, even though they look like that. Be surprised at how unhealthy a lot of bodybuilders really are.
Oh yeah. And especially if they're enhanced and they're just
Yes.
hammering the drugs.
Yes. Yes. Their liver's not happy. Their kid's not happy. It's their heart. I mean, I have personally lost, I think the number's at 9 people in the fitness community who are personal friends of mine in the last 10 years.
Wow.
I'm in their 30s, and a lot of them were taking a lot of enhancing drugs. And, was it the drugs necessarily? Almost every single one of them had a pre-existing something, that was it exacerbated? Maybe. Or was it, hey, they were pushing their bodies so hard that issue just couldn't handle anymore,
Yeah.
So
I remember specifically, I was watching a YouTube video about enhancements, and there was a picture of a coronary artery from autopsy, and it was like you could barely see through it. It was tiny, tiny, tiny.
Really?
So yeah, that's just, and people are becoming a lot more aware of it because of social media and that kind of awareness.
Yeah.
And yeah, but also because of that, a lot of the young people are starting. They're like 20 and they're starting to take steroids.
Yeah, it'd be amazing. I go to the gym every day and I walk around. I'm like, oh my god, this kid's like 17. Yeah.
That's literally me if I were to start steroids.
I'm telling you, I see it in there, and it's like, and sometimes I'll walk over and go, look, you need to be careful. I had a kid that I knew that he was growing up. He was much younger than you. I think he made it to 30, but I knew him since he was, I think, 7 or 8. And he pushed so hard, and he ended up having a massive stroke and heart attack. He was 28. It's like, people don't realize, that it's going to catch up if you push that hard with any medication. I don't care what it is. Alcohol, doesn't matter. It's going to catch you.
Absolutely.
Um,
your health is something so people don't realize how fragile you can be if you push too much.
Yeah.
Right. Like, obviously you should try to push yourself in like areas of your life, like academically, physically, but there's some areas that if you push too hard, it's over.
Yeah. And it happens all the time. And I see it every day in the gym, and you see people, and it's, my main, saying I'm don't really want to be as big as I used to be anymore. I'm trimming down quite a bit. I'm still a big guy, but I'm nowhere near as big as I used to be. I'm very self-conscious or conscious about what I take and what I eat, and how much I work out and the cardio I do. And I'm not trying to be that giant guy. So, like when I have this injury here, of all places, I was fishing in Montana. I wasn't working out, and it's like, man, I can't even get away from this stuff. But but I work really hard to try and stay in good shape, because I want to, continue to do all these fun things. I go backcountry fishing 20, 30 miles back with a 50-pound pack on my back, at 10, 12, 13, or, mostly 12,000 feet elevation, and it's a lot. It's hard on me, but I can do it, and I'm not a young guy anymore, but I'm able to keep up.
Yeah. And especially like if you're looking to get an MD, it'll gain on you quickly, your age.
Oh yeah. Yes, it will. Yes, it will.
So trying to maintain that, your health is so important, staying in shape. What do you think the future of nursing looks like, or what do you hope for it to look like?
I would hope that we would have a little more specialty, categories, and a little more unification, when it comes to the different areas of nursing, and better pay. The pay is, pretty good, but I think that this whole travel nursing thing needs to be not shut down, but it needs to be more carefully regulated. People come from all over different states coming in, and a lot of the facilities I work with and work at, they would rather have a medley or travel nurse come in for 13 weeks, and then leave when they have no knowledge of the facility, no knowledge of the staff, no rapport whatsoever. And instead of promoting a nurse within that is capable and smart and good, and maybe actually knows what they're doing, and for, maybe significantly amount less money, and they don't care. And it's just, and I think that there's some poor management. I think that's poor, business decisions going on. And I think that a lot of these places that I work at and I've seen, that do these kind of things, they're canceling surgery because of it.
Mm-hmm.
I would like to see a little bit more, control, on the the hiring and, the specialization and, who goes where and what, because I don't think right now there's no guidelines. I get calls from, travel nursing companies every day. Every single day I get 4 or 5 different ones. Are you ready to go here? Are you ready to go there? It's like, I mean, no, I'm not. So I'm not really sure, if that would be something that's feasible, which I think will be a pretty big feat to, conquer. But I think that maybe if we unified a lot of nurses almost to like a some kind of union of some sort, I think it might be a pretty beneficial. But then again, I've seen what unions do, and I'm not a big fan. So it's kind of like you're damned if you do and you're damned if you don't. So but yeah, I mean, maybe a couple facilities setting the example, setting the tone, and really working hard to get these nurses the positions they want and training that they need to be successful and retaining them. So
Yeah. And as you said before, having the rapport with the doctor is very important.
yeah.
If you're switching every 13 weeks or something like that, you can't build that skill
Yeah.
or that relationship.
I don't actually think a lot of them care. Actually, I think that with I think I'm gonna go back to that question you asked me. I think that the biggest problem and change that I would like to see in nursing is I would like to see them go back to the NCLEX that they had. I don't want to see a bunch of new grads coming out that don't know anything. I don't want to see them come out because they passed the NCLEX and it was cake. It was hard for a reason. There's a reason why it was that difficult, because otherwise all these people could do that. And I don't really want all these people. I want people who know what they want to do, are smart, working hard, and studied hard to get that job, instead of someone who took the easy way and got this cheap, the NCLEX and, that they took now. And it's like, okay, I passed it. Yay. And here we are, and now they have no knowledge whatsoever. They come out of school and they may know a couple values, but they have zero knowledge and zero real world experience.
Yeah. And that's a problem for the patients. Like, yeah, it's not good for the nurses that are coming in and they don't really know that much. But if you're a patient on the other end and you are with a nurse who is not prepared to take care of you, I don't know what I would do. It's just,
Could you imagine walking in, and you're having, let's say, an appy, and the nurses, doing their head to toe, their quick, 2-minute, head to toe evaluation, which doesn't exist. I don't know if you've ever seen a head to toe, a correct head to toe, but we do a focus. We don't, in the ER, we don't do a head to toe. We do a focus assessment. We come and look at you, and we go through, a couple quick things to kind of rule out what's going on. And in 30 seconds, I'll have an idea what's going on. I mean, but that's just me, and if I don't, I'll take another look. Something's not adding up. You got a white cell count of 30,000, but you're looking at me like you're perfect. I had a nurse the other day go, maybe an appy, maybe this. I'm like, an appy. They don't have a fever, and they're not tender, and they look perfect. And I waited for a second. I'm like, hey, doctor, how's cancer sound? He's like, bing. He's like, yeah. And I looked at the other nurse, and he's like, but why? I'm like, never mind, bro. I give up. I'm not going down that road. I just don't have it in me, and if you don't understand that, then that's very simple. It's a very simple diagnosis. Hey, which one? I'm not going to go that route. That's not my job. But I'm going to tell you right now, you got a white cell that high. There's some sort of leukemia going on. You got something going on that's causing that to be high, but you look perfect. So, but yeah, and that's going to be it,
yeah. You kind of sprinkled this in throughout the interview, but what advice would you give to someone going through the nursing path who's very, very focused and dedicated, but it's just having some doubts or is struggling a little bit?
Try and get a job at a hospital. Try and go get a part-time job at a hospital, because you will know right away whether or not you are suitable for the job. Yeah, because if you don't do that and you go through all that school and you realize this is not for me, you wasted a lot of time and you wasted a lot of money, and you burdened the nursing industry.
Yeah, like as a nursing student or as a
tech, you can get hired as a tech.
Okay.
Tech is simply someone who has EMS training and BLS, ACLS, and that's it. It's all you need.
Okay.
Yeah, that's all you need. You can get hired on, and a lot of places hire you. Yeah, you're not going to make a bunch of money, but you're going to learn right away. And you're probably going to get through school better, and you're going to come out and you go to nursing and you go in there and you go to get work. You're going to know a hell of a lot more about patients and talking to them, and and patient rapport, and all the rest of it, how to talk to them, how to set up things, how to put an IV in, etc.
Yeah, that's huge. Just experience in everything.
And everything, and some of my techs are so good. I'm like, you know what? You're going to be a great nurse. I've actually told that to a few of them. I'm like, you're going to be a really damn good nurse. I can't wait to have you on board.
Yeah, that's a great compliment.
It is. And for me, it is, because I don't give them out very often.
Yeah,
And I mean, and as arrogant as that may sound, I pride myself on giving people the credit where it's due.
Yeah. I mean, especially when participation trophies and stuff like that. But
Yeah.
that's a whole different debate.
Let's not go down that rabbit hole. Trust me. Let's not go down that rabbit hole, because I'm not that guy. There is a winner and a loser for a reason. Participation trophies do not build character.
Yeah.
I'm sorry. Losing is a very, very strong thing to learn.
Absolutely.
Very powerful, very strong. It makes you a very strong individual because of it.
I would tend to agree with that.
Good. Yeah.
Well, Kelly, thank you so much.
My pleasure.
It was a great interview. I had a blast.
I appreciate the time, and I enjoyed it, because it's a lot of things that I'm very passionate about. This, I've done it for a long time. I enjoy what I do. I have the privilege of working at your dad's facility, which is really amazing. It's a great facility to work at, and I have a lot of really good doctors around me. And there's not a day that doesn't go by that I don't learn something, and that's where I thrive. If I'm not learning something, I don't want to be there. I actually took a job working as an ER nurse at another facility here and there. And the first day I walked in, I realized I'm not going to learn a thing here. I'm not going to learn a thing here. I'm going to be basically babysitting, and this is not for me. And I walked up to her and I said, this is not my facility. I'm sorry. I said, I will work a couple shifts for you and fill in some gaps, but I cannot work here. I said, this is just not, this is somewhere that I will not thrive in, and I will dread coming here every day, and I will not do that to you or myself. Yeah, she understood, and she appreciated it, and I do my best not to insult her, but it's just, I work too hard, and I think that my skills could be used elsewhere.
Yeah, then you got to be powerful and confident.
You got it, yes. So, but yeah, I appreciate the interview, and we will look forward to seeing it, and we'll talk again soon.
Yeah, absolutely. Maybe we can get a workout in sometime.
If you can handle it, come join me. I'm only one arm right now, so you got a chance.
Okay. All right. Thank you so much, Kelly.
Alon, thank you so much, sir. You have a great night.
You too. You too. Thank you.
Bye-bye.
Thank you so much for listening. I hope you enjoyed. If you don't mind, please leave a like and subscribe. And with that being said, see you in the next one.